Okay, hi everyone. Thank you, Julia, for introducing me. And so I'm going to dive right in. Okay, so the objectives of this talk is, first of all, to be able to identify and distinguish features of sickle cell trait, sickle cell anemia, and other sickle cell diseases like hemoglobin SC disease and S beta thal. The chunk of this talk is going to focus on recognizing and managing acute complications and emergencies associated with sickle cell disease. And then I'm going to touch a little bit on understanding the indications for transfusion in sickle cell disease and routine health maintenance in these patients. Okay. So when we say sickle cell disease, it actually refers to all the genotypes that cause sickling and not just hemoglobin SS. Hemoglobin SS is called sickle cell anemia specifically, but sickle cell disease includes all of these four conditions that I've listed. So you have hemoglobin SS, hemoglobin S beta 0 thal, which means that, on one chromosome you have the point mutation that's typical for sickle cell, and on the other chromosome you have basically absence of beta globin. And hemoglobin SC disease and hemoglobin S beta plus thal. I've highlighted hemoglobin SS and hemoglobin S beta 0 because these are the ones that have more severe phenotype, and the other two tend to be milder. And when we say sickle cell trait, this is not a disease. This is very different. These people have normal CBC, they have normal peripheral blood smear. They typically do not have any markers of hemolysis. And this is what their typical hemoglobin electrophoresis looks like. And these are numbers that you should remember. They might ask you in the boards, and even just as a medicine resident, you should know these. So hemoglobin A would typically be more than 50%, and hemoglobin S would be less than 50%. And the usual ratio is about 60-40. And they'll have normal hemoglobin A2 and hemoglobin F. These patients have normal lifespan, but they're predisposed to some medical problems, and these are typically renal complications. So they can have hypostenuria, which means decreased ability to concentrate urine. They can have hematuria. They're at increased risk of CKD, which is 2 times higher than the general population. And they're also predisposed to developing renal medullary carcinoma. And rarely, in extreme situations, they can experience severe splenic infarction. There have been case reports of this happening at high altitude, or they can have Vasoclusive crisis during intense physical activity, military training, just extreme conditions. Okay, and this is a table that I think you guys are familiar with, but just to revise it really quickly. So the first thing right here is your hemoglobin AS, which is sickle cell trait. We discussed about this. The typical ratio is 40-60. And hemoglobin SS, you would not have any hemoglobin A, and you would have more than 90% hemoglobin S. And their hemoglobin is usually about 6 to 9, which is similar for hemoglobin S beta 0. And both of these conditions have a clinically severe phenotype. So what really distinguishes them is a really low MCV. So when you see MCV less than 70, you should question if this is sickle cell anemia, which means hemoglobin SS, or is it S beta 0. And then these last two, hemoglobin SC and hemoglobin S beta plus, these are also similar in the sense that they tend to be milder. And how you would differentiate these is based on hemoglobin A percentage. So hemoglobin SC would not have any hemoglobin A. It would basically have 50% hemoglobin S and 50% hemoglobin C. So that's easy to remember. And then hemoglobin S beta plus would have some amount of hemoglobin A, usually 10 to 30%. And like you can see, these patients have lesser degree of anemia and lesser degree of reticulocytosis compared to the other two genotypes. Okay, so talking about acute complications of sickle cell disease, the most common, the most common reason for hospitalization in these patients is vasoocclusive crisis. You know, 1/3 of these patients actually suffer from daily pain, which is quite sad. So a majority of them would actually be used to managing this pain at home, and they're already on oral opioids. And when they come to the hospital, you know, they really have to be treated with IV opioids. Triggers like, you know, are cold, dehydration, any sort of stress, infection. So you should, in your review of systems, ask for these triggers and specifically try to look for a source of infection. And what makes it really challenging is that there is really no clinical or laboratory finding that exists to diagnose this. And the absence of hemolysis or their hemoglobin being stable at their baseline does not mean that they're not having a vasoocclusive crisis. So that's, you know, that's no reason for withholding pain medication. So you really have to go by what the patient or their family is reporting, and you have to take them at face value. So management, you know, there are like 6 major things that you think about, and this is common to every complication associated with sickle cell disease. So there's pain control, hydration, searching for infection and treating it, incentive spirometry, oxygen supplementation if they're hypoxic, and thinking whether or not they need a blood transfusion. And these are the things that, you know, you should always keep in the back of your mind when you see a patient with sickle cell disease. When I talk about pain control, you know, it really has to be rapid assessment and pain control. Ideally, we would like for these patients to get their first dose of an IV opioid within 30 to 60 minutes of coming to the ER. And they need to be reassessed because, you know, just giving them the first IV dose, it may not be enough. So you have to go back to the bedside and check on them again in 30 to 60 minutes to see if that dose worked or not. And if it did not, you have to give them a higher dose. When I say hydration, we usually give them maintenance fluids, which is about like 1 to 1.5 cc per kg per hour. And unless they really appear dehydrated, the fluid of choice is half normal saline or D5 half normal saline. And the reason for that is hypernatremia causes the sickle cells to become more dehydrated. So we do not want that. So we like to give them half normal saline. But if you feel like they are volume down, then it's totally appropriate to initially resuscitate them with normal saline and then switch to half normal. And what else? The others are, I think, self-explanatory. Yeah, and the blood transfusion is something that's not always indicated, especially if they're having an uncomplicated painful episode, which is like typical of their vasoocclusive crisis, and if they do not have any symptoms suggestive of symptomatic anemia and their hemoglobin is almost at their baseline, so you don't have to transfuse them. So, you know, if somebody lives in hemoglobin around 6 to 7 and they're coming in with a pain crisis and their hemoglobin is like 6.3, you wouldn't transfuse them. It's, you know, very important to ask the patient, does this feel like your typical crisis or is this something different? And because if it is something different, you should be looking for other causes of pain. And very important to do a complete review of system because these conditions are often associated with things like acute chest syndrome. Like over 50% of patients with acute chest actually present initially with a vasoocclusive crisis, and then it progresses to acute chest syndrome. If they're complaining of chest pain, it could just be ribcage pain from vasoocclusion, but it could very well be an MI or PE. And, these patients are at an increased risk of these complications. So, make sure you do an EKG if they're hypoxic, low threshold for doing a CT angio. Examine their abdomen. They're known to have complications like cholecystitis. They can have splenic, hepatic sequestration crisis, especially if they're also anemic from their baseline. If they're complaining of flank pain, think about acute papillary necrosis. And if they've received recent blood transfusion, a delayed hemolytic transfusion reaction is something that can present very similarly to a pain crisis, especially presents with back pain. And then sometimes it can be opioid withdrawal if they haven't been receiving the correct dose of opioids. Okay, and then you should also look for localized causes of pain like septic arthritis, AVN, osteomyelitis. So really don't be anchored to that this is just a vasoocclusive crisis. Think about all the other complications that can happen. Okay, now moving on to acute chest syndrome. This is the second most common cause of hospitalization in these patients, but it is the leading cause of death. And the recurrence rate is really high, 80%. So if somebody's had their first episode of acute chest syndrome, it's very likely that they will recur. So every time you admit a patient, always ask them have you had acute chest in the past? Diagnosis is fairly simple. It's just defined as a presence of new radiographic evidence of new consolidation or an infiltrate. And it's typically associated with clinical signs like fever, chest pain, cough, dyspnea, hypoxia, tachypnea, increased work of breathing. The important thing to note is that chest X-ray findings can be delayed for up to 12 to 24 hours. So important to pay attention to clinical symptoms. And these are almost always associated with a vasoocclusive pain crisis and usually occur within 48 to 72 hours after hospital admission for a pain episode. And especially if the patient is having rib cage pain, those are the ones that are at a higher risk of acute chest syndrome. So causes are usually multifactorial. It could be because of a pneumonia plus hyperventilation. Hyperventilation could be due to pain, that they're in so much pain that they're not taking deep breaths, or it could be oversedation from the opioids. And then sometimes you can have a PE and or a fat embolism. And usually if it's associated with fat embolism, those episodes tend to be more severe and are associated with multi-organ dysfunction. In terms of workup, I don't think there's anything special. These are things, pretty intuitive, but definitely please send a hemoglobin fractionation. And that is something that you should be sending for every sickle cell patient who gets admitted to the hospital. Management is very, very similar to what we discussed for an acute pain crisis, but the mainstay is antibiotics and blood transfusion in this case. So pain control, we usually prefer PCA, fluids we spoke about, oxygen, incentive spirometry, antibiotics. You want to cover, for community-acquired pneumonia, so you typically use third generation cephalosporin plus macrolide, or you can use Levaquin. In coming to blood transfusions, so when do you decide to transfuse someone and what kind of transfusion? So you can do simple transfusion or an exchange transfusion. Simple transfusion is indicated for mild to moderate cases, and the goal is to increase the hemoglobin up to 10. You really don't want to go more than 10 because hyperviscosity and volume overload is also something that we want to avoid. And an exchange transfusion, that's for more severe cases, and the goal is to lower the hemoglobin S to less than 30%. And how do you define a mild case? So a mild case is someone who is hemodynamically stable, not requiring too much supplemental oxygen, usually less than 4 liters per minute. And they don't have a very extensive lung involvement. It's usually limited to a single lobe, and they have no evidence of multi-organ dysfunction. So, this is like going by definition and severity, but oftentimes what dictates these decisions is how soon can you get an exchange transfusion? Because in order to get that done, you have to place a VASCAT, and the patient, then you have to inform the blood bank. The blood bank will call New York Blood Center, and then somebody from New York Blood Center has to come with a big machine, and all of this takes a lot of time to coordinate. So, even if they have a severe acute chest, but it's going to take hours before they'll be able to get an exchange transfusion, you always start with simple transfusion. And the other thing that factors into this is their hemoglobin. So if they have severe ACS, but their hemoglobin is 5, you don't really want to exchange them until their hemoglobin is higher than that. And you achieve that by using simple transfusion. And if you give 2 to 3 units of blood to someone whose hemoglobin is 5, it's basically equivalent of doing a partial exchange transfusion. And similarly, if the patient's hemoglobin is already 10, but they have moderate ACS, then you don't want to give them a simple transfusion to increase their hemoglobin beyond 10. You would rather exchange them. And sometimes you can get away without transfusing them. And this is usually for patients who are very well appearing. They are not requiring any supplemental oxygen. And they only have a low-grade low-grade fever and a small infiltrate on the chest X-ray. Those you can just monitor without transfusion. Okay. So preventing this is really important. Like we said, it's almost always associated with a vasoocclusive crisis. So you really, really need to manage a simple pain crisis well. And incentive spirometry, I cannot stress upon this enough, but you need to educate your patients about using this. And I've seen so many patients who have this at their bedside, but they have no idea on how to use this, and nobody explained them. And I actually, when I was an intern, I also did not know how to use this properly. So I'm going to go over a quick video on how to use this, just so that all of us can explain to our patients. Let me,
Is there supposed to be audio on the video?
Yeah, can you hear it?
No, I think when you share your screen, you have to share with sound. So, so you should maybe stop sharing your screen and share again, and click share with sound so that we can hear.
I'll share sound.
Well, I'm just curious, can people put in the chat, do they think people are blowing out or breathing in?
But breathing in.
Very good. Patients automatically think they're blowing out. This is why it's so important to tell them how to do it. I love that you're showing this, Shivani.
Yeah, I realized that I actually did not know it when I
Okay,
was an
first let's
intern.
go over some wrong ways to use an incentive spirometer. A lot of times if patients haven't been educated properly, they will do what they think you're supposed to do naturally with it by blowing into the device rather than actually inhaling from the device. Another wrong way patients may try to use an incentive spirometer is by quickly inhaling and exhaling off the device like this. Now let's look at the right way to use the incentive spirometer. Okay, first what you want to do is you want to set the goal for the patient with the yellow marker so they know where they need to get whenever using this incentive spirometer. Then you're going to have the patient set up and exhale completely. Then have them seal their mouth around the mouthpiece tightly. And they will inhale slowly and deeply, making sure to keep the yellow indicator on the side within normal range. They don't want that little yellow piece to go too high or too low. And as they do this, the piston will rise up. And have the patient keep inhaling as deep as possible until they can't inhale anymore. And then they'll need to hold their breath for 6 seconds and then exhale slowly and allow the piston to fall before repeating again, and record the amount that they were able to get on the incentive spirometer. And they will perform this at least 10 times every hour or two while awake. So this is what it looks like in action.
Okay. So next we come to, talking about acute symptomatic anemia and sickle cell disease. And there are a few conditions that you should think about when somebody presents with hemoglobin that's more than 2 grams lower than their baseline, and they're having some symptoms from it. First of all, you have splenic sequestration or hepatic sequestration crisis. You can have aplastic crisis. You can have a delayed hemolytic transfusion reaction in somebody who's been multiply transfused. They can also have autoimmune hemolytic anemia for the same reason. Patients who've had multiple transfusions tend to develop autoantibodies along with alloantibodies. Hyperhemolysis, which is rare, but something to think about because it can be life-threatening, and the management is different. And the usual folate deficiency if they're not on a folate supplementation, and iron deficiency is usually rare. Usually we think about like iron overload in patients who've been transfused a lot, but somebody who's not been transfused that much, and if they have ongoing blood loss, then for sure check for iron deficiency. So let's talk a little bit about splenic sequestration. So this happens because these RBCs are less deformable. They go and get stuck at the, in the capillaries within the spleen. And you don't really see this in patients with hemoglobin SS or hemoglobin S beta 0 because, they have already auto-infarcted their spleen as early as like less than 2 years of age. So you would see this in milder forms of sickle cell disease like hemoglobin SC or hemoglobin S beta plus thal. And presentation would be, it's typical. They would have some left upper quadrant pain, fullness, tenderness. You should be able to feel a spleen on exam. And they've dropped their hemoglobin by more than 2 grams from baseline. And it's accompanied by reticulocytosis, which is what differs it from aplastic crisis. Treatment is, you want to transfuse them, but what's important is that you don't want to over transfuse. You want to do it very slowly and just 1 unit at a time, because what happens is as their vasoocclusive crisis improves, these RBCs tend to unplug from the spleen and they come back into the systemic circulation. So all of a sudden you'll have this, volume overload and hyperviscosity, and you don't want that. So transfuse slowly and just 1 unit at a time. And the same thing goes for hepatic sequestration. The acute aplastic crisis. As we know, this is caused by parvovirus B19 infection, more common in children, but you can see it in adults. And they present with, typical symptoms of anemia, gradual onset of fatigue, dyspnea, syncope. They can have fever. Their hemoglobin tends to be really low, like sometimes something like 3 to 6 grams per deciliter. And the hallmark is decreased reticulocytes, often less than 1%. And this will get better on its own. It usually takes, anywhere between 2 days to 2 weeks. But in the meantime, you just support them with transfusions. And this should not recur because they develop lifelong humoral immunity after the first episode. But they can sometimes have aplastic crisis because of other viral infections. Okay, a little bit about transfusion reactions and hyperhemolysis, just because these patients get transfused a lot. So acute transfusion reactions, acute hemolytic or non-hemolytic transfusion reactions are pretty much the same as you would see in any other patient. They're not any more common in these patients. But what you do see at a higher rate is, alloimmunization as well as autoimmunization. So alloimmunization means that you're developing an antibody which is reacting with, other persons or donor RBCs, and that can lead to delayed hemolytic transfusion reaction, which happens anywhere between 2 days to 2 weeks after you've been transfused. At the same time, they can develop antibodies which attack their own RBCs, which are called autoantibodies, and that can lead to autoimmune hemolytic anemia. So in these patients, you should always ask them about their prior history of transfusions. Have they had reactions in the past? Have they ever been told that they had antibodies to red blood cells? Did they have difficulty obtaining blood for transfusion in the past? And there's this other entity, which I mentioned earlier, called hyperhemolysis, and it can be difficult to distinguish, these hemolytic reactions with hyperhemolysis, but usually in delayed hemolytic transfusion reaction, it is the donor RBCs that are being attacked. So it's the hemoglobin A containing RBCs that are being hemolyzed, whereas in hyperhemolysis, you have bystander hemolysis of the patient's own hemoglobin S containing RBCs as well, along with the donor RBCs. So their hemoglobin electrophoresis will look different. And, if you have a baseline to go off of, you can interpret these things looking at their hemoglobin electrophoresis. So like in someone with a delayed hemolytic transfusion reaction, you will see that, all of the hemoglobin A has gone away and they're back to just having a lot of hemoglobin S. Whereas in hyperhemolysis, both the A component and the S component would have gone down. And hyperhemolysis can be fatal, and it's treated with immunosuppressants. You usually give them high-dose steroids, IVIG, and they cannot keep up their reticulocyte count to counteract the degree of hemolysis. So we also use erythropoietin stimulating agents in this case. Whereas your hemolytic transfusion reaction is usually managed with, just supportive care, hydration, pain control, and the most important thing is to communicate with the blood bank and let them know that this has happened, so that they can run a full panel to test for antibodies, and future transfusions should avoid, those antigens. Okay. And I mentioned this earlier, but a delayed hemolytic transfusion reaction can also look very similar to just a vasoocclusive crisis, because they both present with pain and can have some degree of fever. DHTR, in addition, can also have some hematuria or hemoglobinuria. Usually what's helpful in differentiating is an LDH, because the LDH would be really, really high in hemolytic transfusion reaction as compared to just a vasoocclusive crisis, and also look at their hemoglobin. In a vasoocclusive crisis, it should not be that much different from their baseline, but in a transfusion reaction, it's sometimes lower to even their pre-transfusion level. And something that you should send for is DAT, which is a direct Coombs test, but it can be negative in 25% cases, so that doesn't rule it out. Okay, moving on to some liver injury caused by sickle cell disease. I just included gallstones here because that's common, but we know how to manage that. So I'll stick to talking about acute sickle hepatic crisis, hepatic sequestration, which is very similar to splenic sequestration, and sickle cell intra-hepatic cholestasis, which can be like really life-threatening. So acute sickle hepatic crisis basically means vasoocclusive crisis happening within the liver. So these patients have right upper quadrant pain, jaundice. They tend to have leukocytosis, but this is not that bad. Usually their hemoglobin is less than 15 and their ALT is less than 300. And you treat it like you would treat a pain crisis, plus you consider doing an exchange transfusion, depending on their hemoglobin and their severity. But when it comes to sickle cell intrahepatic cholestasis, this happens because of sickle cell blocking the hepatic sinusoids, and this can be really severe. They can have very, very high bilirubin, more than 50. Their ALT, AST can be in the thousands. They tend to have coagulopathy. They can go into hepatic encephalopathy and multi-organ dysfunction. So this is something that we should be aware about, and you do typically do an exchange transfusion for them. Just a quick word about renal papillary necrosis. This is this happens due to medullary infarction, and it's not that uncommon. It happens in 15 to 30% of patients. It can present with painless or painful hematuria with flank pain, and you have to look for an obstruction, an infection, a UTI, and offending medications like NSAIDs. And the treatment is hydration, alkalinization, because alkalizing the urine is supposed to prevent injury from heme pigment. And you treat the underlying infection, you stop the medication that might be contributing, and you relieve the obstruction. And last but not the least, we have priaptism, which is, like you all know, sustained unwanted painful erection. And this happens because of veno-occlusion by sickle cells, which causes decreased venous outflow, and then it leads to congestion. And it's extremely painful. It can lead to permanent erectile dysfunction. You should always ask these patients about any recreational drug use, or are they taking Viagra or something like that? And treatment depends on the duration of it. If it's only like brief duration, usually less than 3 hours, then you treat it like a usual pain crisis with IV hydration, pain management. You can give them oral vasoactive agents like pseudoephedrine. But if it's prolonged more than 4 hours, then you have to call urology, because at that point, it's considered like a compartment syndrome, and they're at risk of permanent erectile dysfunction. And what they would usually do is aspirate the blood from corpus cavernosum with or without irrigation, and then you inject an alpha agonist. There is no clear evidence about transfusing these patients, so I won't talk about that. Okay, so now moving on to just what are the appropriate indication for transfusion. And I alluded to this before, but just to make it a point, the largest misuse of blood transfusion therapy is simple transfusion in adults with sickle cell disease who are admitted to the hospital for an uncomplicated vasoclusive pain episode without symptomatic anemia. Because in this situation, there's no evidence that transfusion will abate the pain episode. But the conditions that you would want to transfuse, you think about it as either acute indications or prophylactic indications. Acutely, it's usually in patients who have multi-organ dysfunction, hemodynamically unstable, they have acute chest syndrome, they have a new stroke or a TIA, and they have an acute drop in their hemoglobin, which could be like aplastic crisis or acute hepatic or splenic sequestration, or like anybody who has symptomatic anemia and their hemoglobin is significantly different from the baseline. Prophylactic indications are more, these are more outpatient, but we do transfuse them preoperatively, depending on what kind of surgery they're going for, but the usual goal is to have a hemoglobin of 10. And for someone who's had a stroke or has had recurrent TIA, has had silent cerebral infarcts, they are usually placed on chronic transfusion therapy where they get monthly transfusions. And they sometimes consider it for patients who've had many acute chest syndromes despite being on disease-modifying therapy. And just a quick word about routine health maintenance for all sickle cell disease patients. And this is also more relevant to the primary care and ambulatory setting, but please make sure that they're vaccinated. You can also check their vaccination status when they're in the hospital. And, because these patients have functional asplenia, they need to be immunized against encapsulated organisms like pneumococcus, H. influenza, meningococcus. They should definitely get their annual flu vaccine and for sure COVID vaccine. They should be getting an annual eye exam for retinopathy. They need, just like diabetics, they should also be getting an annual urine protein creatinine ratio. Just an important point, serum creatinine is a poor marker of renal function in patients with sickle cell disease. It tends to overestimate their renal function because these patients have hyperfiltration and they secrete creatinine into the renal tubules. So it can be falsely low even if they have renal dysfunction, sorry. So you have to follow their urine albumin or protein creatinine ratio annually, and then you start them on ACE inhibitors if they have microalbuminuria, just similar to what you would do for a diabetic. They should also get an echo, usually a baseline echo, and if they don't have symptoms, then you don't need to repeat it. But for somebody who has a severe phenotype, you usually do an echo every 1 to 3 years to monitor for pulmonary hypertension. And then always make sure that they're on folic acid. And if they're being admitted to the hospital and they're not on hydroxyurea, you should make sure that they establish follow-up with a hematologist and be started on a disease-modifying therapy. And then patients who've had many transfusions in their lifetime, usually more than 20, they're at risk of iron overload. So, just something to keep in the back of your mind. We usually follow them with ferritin levels, but they can present with endocrinopathies. So we check their TSH, hemoglobin A1C. You might have to, if they have really high ferritin levels, more than 1,000, you do a liver MRI, and if they have any cardiac symptoms, you do a cardiac MRI. Okay, do we have time for some questions? Okay. So, does anybody want to volunteer to read the questions?
Guys, otherwise I'm gonna call you. I see Tina. Do you want to read the question?
Sure. So a 24-year-old woman is evaluated for severe pain in her arms and legs of 5 hours duration. Medical history is notable for lifelong mild anemia, 4 episodes of similar pain without precipitating factors, each episode resolving in 3 to 4 days. She has a cousin with sickle cell disease. She takes no medications. On physical exam, vital signs are normal. She has normal range of motion in all joints, no skeletal deformities. And what is the most likely diagnosis?
Yeah, just based off the hemoglobin electrophoresis. You guys can type the answer in the chat.
Yeah, so let's look at the electrophoresis. What do you guys think? Oh, we can see the answer now.
You can see, oh no.
I think you
Okay,
shared.
my bad.
Yeah.
Yeah, I shared the wrong screen. I don't know how to like pull up the chat in this view.
So I think
I can read out the chat if you want.
Yeah, thank you.
Yeah, some said S beta.
Yeah, so it is S beta because you have hemoglobin A. You would not see hemoglobin A with hemoglobin SS disease, and you would not see a hemoglobin A with hemoglobin SC disease. You would see like 50% hemoglobin S and 50% hemoglobin C, and then sickle cell trait would not present with any symptoms. So it is hemoglobin S beta thal. Okay. Next question, if you want to find another volunteer, Julia.
Emily, do you want to read it out?
Wait. Hi. A 21-year-old African-American man with hemoglobin S beta thalassemia is admitted for uncomplicated pain crisis of chest and back. He is placed on a patient-controlled analgesic pump with morphine, ketorolac, and maintenance IV fluids. He is afebrile with vital signs stable, SpO2 of 98 on room air. His past medical history is significant for mild to moderately severe sickle cell anemia with 1 or 2 pain crises a year, and mild asthma, for which he takes albuterol. His hemoglobin is near baseline at admission, 7.8. On the 3rd day of hospitalization, this patient develops a fever of 102, SpO2 of 92. On his exam, breath sounds are decreased at the bases. His chest x-ray shows bilateral lower lobe infiltrates. His hemoglobin 6.8. What's the next step after initiation of antibiotics?
You guys can just like type the answers in the chat.
They're saying A.
Okay. A it is. Yeah, so it is, he does qualify for like moderate to severe ACS, I would say, but you wouldn't wait for performing an exchange transfusion in 6 hours. You would go ahead and do a simple transfusion as soon as possible. Next question.
Anyone volunteers, or I'll volunteer someone? Nobel?
Yeah, sure. So 35-year-old man with hemoglobin SC presents with acute pain episode with pain in arms, legs, and left upper quadrant pain and fullness. He is on chronic transfusion therapy and last received a blood transfusion 7 days ago. On exam, left upper quadrant tenderness, splenomegaly, and his current hemoglobin is 5.3. Baseline hemoglobin approximately 8. Retic count is now 12%. What is the most likely diagnosis?
Cheryl is saying B. Everyone is saying B.
Yeah, this one was really easy. Okay. Next one.
Patricia?
22-year-old African-American man with hemoglobin SS disease requires a cholecystectomy for persistent abdominal pain secondary to cholelithiasis. His surgeon requests recommendations for preoperative transfusions. The patient is not on any disease-specific therapy. His hemoglobin level is 7.5, and his hemoglobin S percentage is 88%. What do you recommend?
I'm sorry, I forgot to like put in the alphabet. But yeah, it's just A, B, C, D.
Yeah. What do you guys think? They're saying E.
That is correct. Yeah. So,
Some
you know,
saying
before any elective surgery, you do want their hemoglobin goal to be at 10. So you normally do simple transfusion to bring it up to 10. But if they're undergoing a major surgery, like something like a cabbage, then you would do an exchange transfusion and make sure that before going into the surgery, their hemoglobin is less than 30%. But because cholecystectomy is like an average intermediate risk surgery, simple transfusion to a goal of 10 is the answer. Okay.
Anyone? Cheryl?
Sure. A 22-year-old woman is seen for a routine prenatal evaluation. She's 10 weeks pregnant. This is her second pregnancy. The first pregnancy was uncomplicated. Medical history is notable for sickle cell disease, requiring 1 to 2 hospitalizations per year for painful events. She has no history of a stroke or acute chest syndrome. Her only medication is a folic acid supplement. On physical examination, vital signs are normal. Cardiac examinations reveal a grade 2/6 systolic flow murmur. She has a gravid uterus. A laboratory study shows a hemoglobin level of 6.4, and at baseline it was 5.27. Leukocyte count is 11.5, and platelet count is 279. Which of the following is the most appropriate treatment?
Sorry, I really should have put the alphabets, but
Yeah. I mean, they are saying B.
B, simple transfusion.
I think so.
Yeah, so actually in pregnancy, if their hemoglobin is at baseline, and even if it's like 6.4, which is low, you don't really transfuse them. And you wouldn't give hydroxyurea to anybody who is pregnant. It's like completely, like absolutely contraindicated. So expectant care actually is the answer, because she doesn't have symptoms from this anemia. It's at her baseline. So you wouldn't do anything about it. And the flow murmur is physiological in pregnancy.
I have a question though. Like
Mhm.
a person having a like natural delivery with a hemoglobin of like 6.4, like I don't know, isn't it a risk of like lowering more after like the delivery? Or
Yeah, so because she's 10 weeks pregnant right now, you wouldn't. But that's a very good point. If just before delivery, you would transfuse her. You would give her a simple transfusion, but that's like just right before delivery.
okay.
That's a very good point.
Anyone? Let's see. Debbie?
A 22-year-old man with sickle cell anemia is seen 1 week after hospitalization for acute chest syndrome that required critical care and treatment with exchange transfusion and non-invasive ventilation. He has not had any previous pulmonary or any other major complications from his sickle cell anemia and typically has 2 to 3 episodes of acute pain events yearly. He reports he has returned to his usual level of activity and has no pulmonary symptoms and no pain. His only medication is folate 1 milligram. On physical examination, vital signs are normal. He appears pale. Cardiac examination reveals a grade 3 out of 4 systolic flow murmur. The remainder of the examination, including pulmonary exam, is unremarkable. What is the appropriate management?
So they're just saying D, hydroxyurea.
Yeah, that's the that's the right answer. Yeah, so this person should absolutely be on hydroxyurea. So anybody who has pain crisis or has had acute chest syndrome or any complications whatsoever from sickle cell disease should be on hydroxyurea. But hydroxyurea is not something that you can start in the hospital. It has to be started as outpatient because you need to follow up their CBC very closely and titrate to the maximum tolerated dose. But if somebody is on hydroxyurea at home, you should check what their ANC is when they're getting admitted to the hospital, because if their ANC is like 5, then they're really not at the right dose. You would like the ANC to be around 1.5 to 2,000, because that's the maximum tolerated dose, and that's what you want them to be on. Okay, last question.
A 22-year-old woman with a past medical history significant for sickle cell disease complicated by avascular necrosis of the right hip, presents with 1 to 2 days of continuous diffuse 9 out of 10 pain consistent with the Vasoclusive Crisis. She's found on labs to have acute kidney injury with a GFR of 22. As an outpatient, she's on morphine ER 30 milligrams, Q12 with morphine IR 15 milligrams, Q2 PRN for breakthrough pain. Prior to this, her chronic right hip pain was improving with physical therapy, and in the past 24 hours, she's taken her long-acting morphine, as well as 8 doses of her PRN short-acting medication. What is an appropriate pain medication and dose to try?
Just write in the chat what you think. You can also unmute yourself. This is a tough one.
Yeah, but you don't really have to make calculations. Okay, I can answer this. So you would switch them to IV Dilaudid. So when somebody is coming with a pain crisis and they've already tried their home regimen of PO opioids, you want to give them IV. So like the only IV option was Dilaudid and the other one was Tylenol, and Tylenol is like not going to cut it. And then she has a new AKI and her GFR is less than 30. So in such patients, you would avoid morphine and oxycodone. So Dilaudid and fentanyl are your typical choices for someone who has renal dysfunction. And fentanyl is usually a patch and it takes a while to kick in. So Dilaudid would be your natural choice. We're like running out of time. So I think, I just this is like a quick and easy guide to like how to choose and calculate opioid dose. But I'm happy to like share the slides and you guys can go over it. This is just something you can use at night when you don't have anesthesia, pain management around to start them on a PCA. So you can just do some calculations by yourself and like at least give them the initial dose. Okay, that's pretty much it.
Thank you. Does anyone have any questions? We have maybe time for one question, if anyone has anything. Okay. Thank you so much, Shivani, for giving us this lecture. And if you give me the slides, I'll be happy to share it with them. And you can always reach out to Shivani whenever if you have questions.
Yeah.